use this to share with your colleagues and your coworkers and your board members. And so we wanted to get a lot of the information on the screen to have it handy for you to replicate the use of this PowerPoint. I will be sharing some anecdotes with you, and if you find yourself in a leadership position to be able to use this, I hope that you'll bring your own experiences to the presentation process. So we have an outline here of 4 points. The first thing will be the overview of the 4 categories. The next is the board's role in assuring quality, minimizing risk, and demonstrating compliance. And there's a reason for the color coding here. We're going to, as we talk about quality care, we will be highlighting all of those points in lime green. When we talk about minimizing risk, it will be around it'll be in blue, and as we talk about demonstrating compliance, you'll see that appearing in that orangish color. The third category of the presentation is the practical application in the community and migrant health center setting. I know that some of this information can seem very bureaucratic in process, and we want to minimize that by being as practical as possible about how we these issues, put these tools to work. And the last is a bank of tools and information resources that are available to you. Many of them are available now, and as an incentive to you to produce your evaluation, because we rely on that to make sure that we improve our presentations on a continual basis, we have some additional resources that we will be sending to you by email as soon as we receive 50% of your evaluations. So I hope you'll all step up to the plate and help us with that so everybody can get those materials right away. So we're going to start here with the overview of the 4 categories, and I suspect that many of you are very familiar with these 4 categories. The first, of course, is need. The second is services. The third category is about management and finance, and the fourth is about governance. And it's really important that we've been able to break this down into 4 categories, because when I first started teaching governance issues was about 20 years ago, and we had a 78-page booklet called Expectations, Governance Expectations. And what the Bureau of Primary Health Care within HRSA has done is to distill that 78-page booklet down to about 3.5 pages of just those things that are required by law and by statute. So on the next slide, we have the source documents for all 19 of those program requirements. They are either based in legislation or in program regulation or in grant regulation. And the links that you see on each of these screens are hot links. And so if you have the PowerPoint electronically, you can use those to go to the source to find the information that these 4 categories summarize. So if you ever wonder whether it's real or somebody made it up, it's based in law and in regulation. So why are the program requirements important? First of all, an organization applies for and receives community health center funding, and that's how they become a grantee. They then enter into an agreement with the federal government to comply with program requirements, and that constitutes their contract. And as they move forward with implementation, their performance is monitored and assessed through operational site visits. So that assessment is an important part of the contractual agreement between the grantee and the federal government. We also hope that in addition to being a contractual obligation, it is an understanding that this is what is the common denominator among all health centers across the country. Every health center must comply with all of these program requirements, but as I hope you know, there's a great deal of flexibility that's built into the individual implementation of these contractual agreements. So the first category is a real easy one, and I love it because there's only one program requirement in that. But this program requirement, which is called NEED, is the foundation for the whole process, the application and the implementation. So it should be based, first of all, on mission and strategic planning and delivery of services. And that is the assessment of community needs. And the elements that go into assessing a community's need include the size of the service area, the boundaries, and the physical characteristics of that service area. And then as you move to the right of the screen, we're looking at the needs of the population itself, which include the social demographics of the population, the health indicators, and using a phrase that's becoming more and more frequently used in the last couple of years is looking at the social determinants of health. And I always chuckle when I hear that, because when I first got started working in migrant health about 40 years ago, we didn't call it that. We called it something much less refined. It was responding to the needs of the population. In our case, we're looking at migratory and seasonal agricultural workers who have some very, very unique challenges. So those are today's social determinants of health, which are becoming important for all health center populations, not just special populations. So as we move into the second category, I'm just going to summarize program requirements number 2 through 8, because this is really about governance, and it's important that governing board members understand what these 7 program requirements are and understand the detail that goes behind these brief phrases that summarize them. But I'm going to focus more on the last 3, which are focused on governance. So in the center of this diagram, we have number 2, the required and additional services. And the bottom line is that there is a set of required services that every health center must offer. Additional services are those that they choose based on the needs of their population and their needs assessment. Every health center must have a core staff of clinical staff which is required to provide services, and that must again be balanced with the need in the community and the needs of their population. If you have an elderly population, you need to have staff that are equipped to deal with the elderly. You don't want to have a majority of your clinical staff, for example, be pediatricians. You need a balance based on the population needs. Hours of operation and location are very critical, and those need to be set by the board and implemented by staff. After hours provisions to make sure that if one of the established patients or any of the established patients in a health center operation need care after hours, that there is a way to get a hold of a qualified individual who can advise them and guide them as to how to pursue care. I know as a mother myself, knowing when I needed to take an infant to the emergency room and getting some help and when I could wait until the next day was very critical. Number 6 has to do with hospital care and continuity of care. Again, we want to make sure that when someone is hospitalized, that their discharge includes a return back to the health center with all of the information so that health centers can be responsible for making sure that they're not readmitted to the hospital unnecessarily, that the follow-up is done. Number 7, sliding fee scale or sliding fee schedule discounts to make sure that there's no care denied because of inability to pay. And number 8, the quality of care to make sure that it's assured and continually improved. So on the next slide, we have program requirements numbers 9 through 16. So starting with number 9 in the upper left-hand corner, it's very similar to services. We want to make sure that we have the right management positions and the people that fill those positions have the right skills for the size of the organization. Number 10, to make sure that the contracts or the affiliations that the health center has with community providers and community organizations don't jeopardize the health center's compliance with laws and regulations, because you as a health center are responsible for making sure that anyone that serves as an extension of the health center also complies with the laws and the same laws and regulations that you as a health center are responsible for. It's also important that all health centers work collaboratively in each of their service areas to make sure that care is continually improved. Sometimes we have a tendency to have some little competitions that go on within the community, a perception that one organization does it better than another, and there's really no room for that in today's world. There is so much need, and the need is so great that we need to make sure that we're all working collaboratively. So in the process of submitting an application, the more a health center can demonstrate their collaboration, the better their proposal will read. Number 12 has to do with making sure that the revenues and the expenses of the organization are budgeted and that they're reasonable compared to the services provided and the number of people that are receiving services. It used to be that we would look at an average amount of funding per user per year, which was somewhere around $200 on average nationwide. And we've done away with those numbers, but we still have to look for some balance in that. So since we're talking about board and the board role in relation to these things, the thing that I want to point out is that every health center has staff, as reflected in requirement number 9, that are hopefully the right positions and the right people to manage these things. The role of the board is in oversight, which we're going to talk about a little bit more as we go forward. So program requirement number 13 is, what do we charge, who pays for that, and how do we stay solvent? Because if you remember, in the previous slide, we talked about the fact that health centers have to assure that no care is denied because of inability to pay. But there's an inherent tension between that requirement and this one. Number 14, we have to have policies in place to assure that resources are being managed properly. One of the ways of doing that is through budgeting, which is reflected in number 12 below. Another way of assuring that is through health center board policies and procedures that guide staff in the implementation of those policies. Number 15 talks about data reporting systems and support for management of and oversight of those opportunities, of operations. So only so many words fit on each slide here. So lastly, number 16 is the full scope of our services needs to be defined and ensured, and we'll talk a little bit more about that as we go forward. So if there are any questions on any of these, again, remember our objective here was to give you a broad overview of the 4 categories, which is why I'm moving so quickly forward with these. But if you do have any questions, we'd be glad to try to address them. So the last category of the 4 categories includes only 3 objectives, and these are numbers 17, 18, and 19. And when I do training for board members, I often start with these 3 because these are the 3 program requirements that board members are directly and primarily responsible for. So it's not the job of the CEO to make sure that the scope of authority of the board as the board exercises it is appropriate. It's the role of the board to assure that. Likewise, it is the role of the board as a whole to make sure that the composition, how many members and who are they and what disciplines do they represent, meets not only the bylaws of the corporation, but the requirements of all of your funding sources. And then number 19 is about conflict of interest. So as I move into the next slide, the next 2 slides actually, we are going to go into greater detail on these 3. And hopefully you all downloaded the 3.5-page summary of the program requirements, and you have this in front of you. So under number 17, board authority, there's a handful of things there that the board is responsible for. The first is holding monthly meetings. It's not okay to cancel meetings 2 or 3 times a year because everybody's busy or it's Christmas or there's a lot of snow on the ground. If you miss a board meeting for any reason, it's very important to make it up, and it's also important to make sure that there's a quorum at each meeting. It's important for the board to be responsible for approving the health center budget and grant application, and the board is responsible for the selection and dismissal. We used to say hiring and firing, and that sounded kind of harsh. The selection and the dismissal, providing direction and evaluating the CEO. It's important that the board be involved in the selection of services and establishing the hours of operation. It is important for them to be able to measure and evaluate the organization's progress in meeting their goals and long-term viability. And it's important for them to provide ongoing review of the mission and the bylaws and patient satisfaction. If we don't know where we're going, we won't know when we get there. So it's important to constantly stay on top of that. And then in general, just establishment of health center policies. So in regards to program requirement number 18, which is board composition as we reviewed earlier, the Public Health Service Law, Section 330, requires that there be at least 9, but not more than 25 members on the board of directors. And I often recommend that health center boards have a range of board members. If they want to have closer to 9, make it 9 to 11. Or if you want to have it be 11 to 15. And the reason for that is because you don't want to find yourself in a situation where you've had one board member suddenly leave the board unexpectedly, and you're down to, if your requirement in your bylaws says 9, and you're suddenly down to 8, which puts you out of compliance. But if you have a range, that gives you a little bit of flexibility. And that's an example of where the flexibility that these grant funds are offered. It is important that a majority of those board members are consumers of health services and represent the patient population. And that means they represent them geographically, they need to represent them racially and ethnically, they need to represent them in terms of age, all very critical. The remaining members of the board who are non-consumers must also represent the community, and they represent the community in the way that they bring expertise to the board in a wide variety of community services. That could be banking, it could be real estate, it could have to do with education, higher or secondary or even elementary education. In the case of migrant health centers, collaboration with Migrant Head Start and Migrant Education are very important, as well as the migrant labor programs that are usually in our communities. If you have health center providers or health center administrators on your board as a part of those non-consumer members, those at-large members, it's very important that not more than 50% of them earn more than 10% of their income, their annual income from the healthcare industry, whether that's clinical or administrative. And the reason for that is that we don't want to have external healthcare industry dominating or ruling the health center governance. We want our consumers to be in charge. So the next slide summarizes the program requirements for program requirements number 19. This is the conflict of interest policy, and it's very, very critical that the policies of the board include provisions to prohibit conflict of interest in written board and policies and bylaws. And they must apply to all board members, all employees, consultants, and vendors of goods and services to the health center. It's not allowable for any board member or an immediate family member of a board member to be an employee of the health center. The CEO may serve as a member of the board, but only as a non-voting member. And the last bullet is one that I add. This is not in your document, but I have learned through experience that it's very important not only to avoid the technical conflict of interest as defined by this program requirement and defined by your bylaws, but it's critical to avoid the perception of a conflict of interest, because if there is a perception in the community that things are not kosher, that things are not above board, the damage of just the speculation about a conflict of interest can create a lot of damage to the organization as a whole. So I've got some practical tips for you here, and this comes from my personal experience in being both a health center board member and a health center CEO. And the first is you must act as one body. It may be that there is disagreement around the discussion phase of any item on the agenda of the board, but in the end they have to act as one body. And when the majority votes, even if you were a dissenting opinion in that, it's important that you present a unified body, a unified front. It's important for the board, both as a whole and the individual members, to think and act in systems, because of all of these program requirements, for example, or if you think need and services, management, finance, and governance, these are not silos. They cannot function in silos at the health center level, and they can function in silos at the policy level. The board's role, of course, is to set policy and understand that it's that policy that drives staff direction. And in order to make sure that it drives staff direction, you have to monitor the implementation, not personally, but through the CEO, who is your employee. I highly recommend that you adopt a schedule of board actions because there's a whole bunch of stuff that's predictable on a monthly basis, on a quarterly basis, and on an annual basis. And so, for example, you should be seeing financial statements every month. You should be seeing a UDS at the same time every year. You should be seeing the submission of your grant application to the federal government well in advance of the beginning of your next fiscal year. Securing an independent audit is very important. I once had experience with a health center that had an audit due, and the board didn't realize it was time for the audit. The audit was postponed for several months, and it wasn't until the auditor actually presented the audit to the board that the board realized it was 4 months late. And there was a reason for that that wasn't real straightforward. The next check mark on this checklist, as we discussed at the beginning of the presentation, looking at strategic planning as well as mission is a really important part of focusing on the need and doing the needs assessment. I cannot tell you how many times people do the needs assessment without including strategic planning as a part of the plan. It's important for individual board members to make a commitment to learn the language and the business of community health centers. And sometimes I think it's a foreign language because there are so many acronyms that we use in the work that we do that if they're too frequently used with board members who don't live and breathe this business on a daily basis, it creates a dynamic in which the board members are kind of kept in the dark and don't have a full understanding. So one of the resources that we will be sharing with you at the close of this webinar is an acronyms list that is located. It's ordered in alphabetical order, and it has an interpretation of each acronym for you. And we'd love to hear whether or not that's helpful. If you have anything you suggest we add to it, we'd be happy to do that as well. It is the responsibility of the board to secure training for themselves individually and for others on the board as a whole. And what that means is that when you approve the budget, you need to look at that budget and say, where's the budget for board training? And what is the plan for board training? So it's not necessarily up to the board to write out the plan, but they need to communicate their expectation to their employee, which is the CEO, so that the CEO knows what their wish is, both in terms of, I want to call it extracurricular training that can be achieved at the state level or at the national level, and in case of internal training that's provided to the board as a whole on a periodic basis locally, so can take advantage of that. Very important that you attend meetings on a regular basis and attend committee meetings on a regular basis, that you ask questions and that you question the information that's provided to you, and that you be engaged and participate. It is critical that you be able to provide oversight to assure quality, to minimize risk, and to demonstrate compliance with local, state, federal laws, as well as terms of the contracts. And those contracts may be with insurance companies, they may be with state government for funding that you receive, for example, for the WIC program. All of those, and the next part of this presentation is going to focus on minimizing risk, demonstrating compliance, and assuring quality. So over to the right on this slide, we have a little organizational chart in lime green, and this is just my last and maybe one of the most important reminders, and that is that the board of directors as a whole has one employee only, and all others report to the CEO. And this can be a little bit deceptive because you as a board are responsible for approving the addition of clinicians and other licensed personnel to the health center staff role. So sometimes that creates a false impression that the board members are making those decisions about hiring those people. In reality, what you're doing is you're approving the fact that those providers, those licensed professionals, have been carefully screened, and that we are confident of their credentials, that their credentials are what they say they are. So your one employee is the CEO. So as we move into the next section here, we're going to deal with our color coding here. And I want to talk about the relationship between assuring quality, minimizing risk, and demonstrating compliance in relation to the program requirements, because these are really different things. The program requirements, the 4 sections of the program requirements, are different and yet very similar from these 3 factors. So this screen is designed to show the relationship at the 4 areas or categories of the, if somebody's having trouble with us here, make sure everything's working fine. So we have the 4 categories of the program requirements at the bottom in those 4 circles. We have risk management and quality assurance and quality improvement, also known as continuous quality improvement or program performance improvement, in the green circle. And overarching all of these is corporate compliance. And the reason that we've got the overlapping of the circles as you see them there is because it's almost impossible to separate them entirely from one another. They function as systems together. So QA, QI, CQI, PI, what the heck? What do these things mean? So for the initiated, quality assurance, quality improvement, continuous quality improvement, and performance improvement. These terms, as I said earlier, are sometimes used interchangeably. QA and QI is the combined effort of everyone to make changes that will potentially lead to better outcomes, better system performance, better professional development. It is also a set of systematic, data-guided activities designed to bring about immediate improvements in healthcare delivery. This comes from HRSA and is one of the first things that pops up as you go to their website for information on these things. So here's an example that we've prepared for you of the board's role in relation to quality assurance and quality improvement. And so we have selected program requirement number 8, which, by surprise, is quality assurance and quality improvement. The board's role is to create policies that enable the development of an institutional culture of quality, to adopt a performance improvement plan, which is reviewed periodically as defined by board policy. Board policy that you're going to review every year and approve it, obviously make any changes if they need to be made on an annual basis. If you don't think you can get to that, or if you don't think it's essential that it be reviewed every year, then your policy should say that it's reviewed every other year. It is also the board's role to participate in a quality improvement, quality assurance committee and to assess quality. And sometimes that is a staff committee with seats on it for board members. And sometimes there are 2 committees, one that is comprised of staff and one that is comprised of board members, with information exchanged between the 2. Either of those 2 arrangements is satisfactory. It's up to the board and the staff to decide which one they think will work the best based on the needs of the board and the level of their willingness to become engaged. It's also important for the board to be able to monitor the progress of quality assurance and, I'm going to say, performance improvement by regularly reviewing the results of quality assurance audits, incident reports, performance improvement measures, and recognitions that they may be receiving from the federal government for stellar behavior or stellar performance. Knowing how to monitor for the board as a whole is often a critical issue. And again, it circles back to participation at the committee level. So you have 2 or 3 or 4 of your board members that are participating on a quality assurance, quality improvement committee. but the other board members are not, it's then incumbent on the board members who are committee involved to translate that information, to bring the information on paper and to translate it in living color to the balance of the board. So from here, and remember we talked about the color coding, we're going to move on to minimizing risk. So the reason I selected this graphic is because oftentimes people think of QA, QI, risk management, and corporate compliance as being interchangeable. They're not. They must function in a systemic or a systematic way, but they are unique, each into their own self. So what is risk management? Begins with a mutual understanding that patient and staff safety is everyone's responsibility. It is operationalized, risk management is operationalized through formal written risk management and patient and staff safety program guidelines. Risk management requires systemic coordination of multiple functions across activities of all departments. And it achieves efficiency and effectiveness through teamwork and through participation among management providers, staff, and volunteer board members. So again, it's not siloed. This is not something that can be handed off just to those paid employees. But in every case, the staff of the health center have the primary responsibility on a day-to-day basis, and the board of directors has a responsibility on a broad oversight basis. So we'll talk more about oversight as we move forward. So what types of risk do we manage? There are multiple factors that come together in the operation of a community and migrant health center. Many of them are out of anyone's control, or maybe I should say everyone's control. These include influence of nature, such as hurricanes, tornadoes, floods, and blizzards. I was in Homestead, Florida within 24 hours after Hurricane Andrew hit the South Florida area in 1992 with a favorite photographer of ours, Alan Pogue. And what privilege that was to see and to experience firsthand the risk factors that came into play at our community and migrant health centers in that area. Situational variables include location, facilities, equipment, motor vehicles, and handling of materials. All of those things are situational, and there are things that can go wrong. There are many, many more. Those are just examples of them. And then I have to talk briefly about human variables, and I don't mean to sound dark when I say this, but you know, medicine is in fact a science. And the science of medicine can be very precise in many ways. We've progressed a great deal in the last 100 years in terms of our understanding of medicine, of dental care, for example. However, the science of medicine is administered by human beings to human beings. So the unpredictability of human behavior, whether it's because of the stress related to illness, whether it's because of those social determinants of health, all of those factors can create risk variables. And we see more and more of the unpredictability of human behavior in the news every day today. However, in relation to these factors or these variables, anticipation and preparation are critical forms of risk prevention. So here's a question that I'd like to pause and ask you to just respond to electronically, and that is, what types of risk factors have you experienced at the center? Have you had hurricanes? Have you had issues that have been disruptive or have put your health center, your staff, or your patients, their safety at risk? So if we want to just take a few minutes and ask people to chime in on those, I think we can all see those responses as they come in.
Yes, if anyone would like to answer that question, please enter the question in or your responses in the chat feature, and I can read those to our presenter. And Bobbi, I wanted to take a few minutes now to ask you to check your audio. You seem to be going in and out, and seems like halfway through it sounded a little bit more echoey. I don't know if the volume is too high or if you have anything plugged in. I don't think you were using
don't
a
have
headset, so maybe.
I'm using the speakers, and I did change the volume level. Is that better or worse?
It sounds okay right now. It's just,
Okay.
still sounding a little echoey, a little in and out at times.
Does it help when I speak more slowly?
Well, right now you sound fine.
Okay.
And I don't see any
Okay.
responses coming through in the chat.
So in my experience in running health centers, I've experienced floods and I've experienced droughts that have a lot of impact on health center operations. When I went to Homestead in 1992, we found a health center in Homestead that had been physically damaged. We had another that had been physically demolished, and we had a health center team that was attempting to deliver services with no power and had armed guards standing at the front door of the health center. So if you can just imagine in that scenario the risk factors that might be taking place as you have patients moving through a health center facility.
And Bobbi, I did have one come in, a response came in saying no overarching events, small risk.
Okay, and I think there was another one that just popped up a second ago. It was on and off the screen.
Power outages, suspected gas leak.
And I had, I'm in a health center.
Let me interrupt, Bobbi, one more second. Do you, by chance, is your cell phone moved away from your computer?
Yes, it is.
It is. Okay. Just checking, just because we do have a little bit of interference continuing as you keep talking. It sounds fine, and then in spurts, it kind of moments we hear the interference.
Okay, thank you. So one other experience that I have had that was quite significant for me was to have an employee attempt suicide while in the health center facility. God forbid that should happen, but it's a very traumatic experience. So having a protocol, anticipating what those things might be, how you will function in case of a fire, how you will function in case of a power outage, how you will function in prevention of violence in the workplace. All of those are things that have changed over the last 20 years. The risk factors have increased. So those are the kinds of factors that policies and procedures need to anticipate and respond to. So I did have someone mention that the audio was good for them. I'm grateful, and I apologize for those of you who are having trouble with me going in and out.
Okay. And
going
Bobbi,
to move on. So what?
Okay.
Yes.
I was just going to mention there was another response in there saying more of a second and third plus the additional after the election risk.
Aha. And I just saw another one dealing with flash floods. Yes. I have had a lot of feedback that the environment in our communities and within our health centers after the inauguration this calendar year has had a very serious impact on the anxiety level of our patients and of our staff. And I'm so glad someone mentioned that, because the presence of that anxiety in our health center operations is so critical. It may be most critical with patients, especially if we have patients who are of mixed legal status, but it's also very critical in communities where people are being profiled. So if there is any chance that a car with either employees or patients can be stopped, and especially in the vicinity of the health center, if there's a sense that the patients and the staff are being targeted, that adds to the vulnerability of the health center because of the heightened awareness and the anxiety of employees. So thank you to the individual that mentioned that. So what is a risk management plan? It is designed to take all variables into consideration, and I hope that we've captured all of those that were mentioned, because I'm not sure that a plan written 2 years ago would have included those variables that we've just mentioned, to then support the mission and the vision of the organization as it pertains to clinical risk, patient, employee, visitor, and volunteer safety, and the current and potential business, operational, and property risks. So here's an example of the board role in risks, and this falls into program requirement area number 3, and it is program requirement number 16, which is management and finance. And I think that this is a critical factor that many people don't understand. The issue of scope of project, which is something that has only been added to the community health center world in the last 10 to 12 years, is what defines services as covered by Federal Tort Claims Act. So what is Federal Tort Claims Act? That is, simply stated, the mechanism by which health centers can save nationwide millions of dollars that would have otherwise been paid to commercial insurance companies. And the health centers and their services and their sites are then covered under the governance of the law of the nation. So it reduces the amount of money that has to be paid out for commercial insurance, but it is critical that the federal government, which is now your primary insuring body, know what your sites are, what your services are, who your providers are, what areas you cover, what hours of operation you have, and what populations you serve. Because without that data, and the policies that cover that, they cannot provide you with malpractice insurance. So to read the second bullet, to establish policy and provide oversight to assure that the description of the health center's scope of project in the electronic handbook, EHB, is accurate and current, including any changes as they occur. So I think a lot of times when our project officer says, do this, we just do it without necessarily explaining to the full board why we do it. So first of all, the electronic handbook is really the map of what a health center has in terms of sites and services and providers. And it is a critical tool that's used to assure that everything that's in that electronic handbook or listing of the services provided is then registered for that grantee under Federal Tort Claims Act or federal malpractice insurance. So very important issue. I wonder if that's new information for anyone, or if everyone on this webinar already understood that. So if you don't mind, take a minute to indicate if that was clarification, helpful clarification, or that was something you already understood fully. So just a quick phrase just to let us know, that would be very helpful. I'm going to move on. Again, we're back to this screen that hopefully shows, thanks Ron, that hopefully shows the interrelationships between corporate compliance, risk management, and quality assurance or quality improvement or PI. And so now this time we're going to focus on corporate compliance. If you remember from the diagram, corporate compliance was kind of the overarching dynamic. Thanks, Heather. Corporate compliance is a system of policies and procedures which set forth the ethical conduct of all members of the health center team. And that team includes staff and board members. And we always have to remember that these board members are volunteer board members. They are not paid in any way for the services that they provide. And it allows them as a team to achieve and maintain compliance with all national, state, and local laws and regulations that govern community health centers. So this can include things that might also be in quality improvement. It can include things that might also be included in risk management. But it pertains to the full array of laws and regulations that the health center is subject to. So if you were to develop a compliance plan, how would you go about doing that? Or for board members, if you were looking at a compliance plan, what should it include? Well, you have to have a compliance officer or a compliance contact that's designated, that wears that hat within the organization. It should be a paid employee and someone who is there on a regular basis. It includes identification of need and provision of continuous relevant training. It includes development of open lines of communication between departments and all levels of the organizational chart. Again, there's no room for siloing here, because without that, with siloing, it makes it easy for information to not flow in both directions. It includes implementation of compliance and practice standards. It includes enforcing disciplinary standards through well-publicized guidelines. A lot of times what I see is that there are standards, but there are no consequences to failing to uphold those standards. It includes appropriate response to detected offenses and development of corrective action, and it includes the ongoing conduct of internal monitoring and auditing. Just checking my time here. An example of the board role in corporate compliance in Program Requirement Area 3, numbers 7 and 13, has to do with creating and adopting policies that comply with Public Health Service 330 laws and regulations, and ensuring that no patient will be denied access to care based on inability to pay, and that every effort is made to maximize revenues from patients and government and private and third-party insurance companies. Now that is an intrinsic tension that is built into our health centers. On one hand, we can't deny access to care based on inability to pay, and on the other hand, we have to make every effort to maximize revenues, because if we don't, we won't have the money to subsidize, so to speak, to underwrite the cost of care for those who cannot pay. So how do you apply this in a practical way? And I'm going to go through this. You've seen this slide before. You understand the relationship of the program requirements at the bottom, risk management and quality assurance in the middle, and corporate compliance as an overarching issue. Take a quick look at this screen. What do you see? At first, I saw horses, and then as I looked more closely, I realized that it was a herd of zebras and that the photograph was taken from directly above the zebras. So bring your perspective, whatever that perspective is, and your life experiences and your expertise to the table. Ask and review the data. Create and adopt policy. Engage with staff in the planning process. They shouldn't be isolated from the other. And then review and approve final plans. All too often we ask staff to create the plans, but we don't bring them back for approval by the board. Number 6, delegate authority to implement plans. Ask questions. It's really okay that you don't know what you don't know as a board member. Remember that the people that you work with on staff are people who have been selected because of their perspective and their expertise in healthcare. But you, as board members, have been selected for a wide variety of expertise. Maybe it's because you understand comunidad. Maybe it's because you understand what it's like to be poor and not have money to go to a health center every time you need to. As a board, be responsible for providing oversight. Don't micromanage, but look at the thing from a broad perspective. Monitor progress, and don't forget to celebrate success. So we have some tools here for you. What are the elements of a plan? Any plan. This could be a risk management plan or a quality improvement plan or a corporate compliance plan. But these are the steps that you would go through to put that together. So if a staff member or a team of staff members brings you a plan, check and see if it's got all of these elements. Use SMART goals or objectives. Don't just say, we want to serve more patients. We want to say by January 1st, we want to serve 20% more patients. Make sure that's an achievable goal. Make sure it's realistic. Make sure that it can be done in a timely basis. It's not necessarily something that's 10 years from now. And I like to add not only timely but time specific. So let's make sure we know when we're going to measure that to find out if we've accomplished our goals or our objectives. Here's another tool. It's called the PDSA model. I haven't been in college in a long, long, long time, but I have younger people who work with me who are fresh in their educational achievement, and this is one of the new models that's been introduced in the last 5 years. Plan something, do it, test it, study it, act, and then repeat it. You don't have to have everything perfect. This model facilitates continuous forward improvement. It helps you to overcome paralysis of perfection, and it allows for small-scale piloting of ideas and programs prior to full-scale implementation. Additional tools that we have available for you, some of which you've already downloaded and some of which you will receive after you submit your evaluation, include those that are located on our website. We have, here's another screenshot of tools that are available on the NCFH website. Especially for this presentation, we've created what we call the ABCs case studies, and there's 2 really valuable case studies in there along with discussion questions. And on the right-hand side, you have the list of acronyms that I promised to you earlier. I love this resource from the National Association of Community Health Centers. It is available in English and in Spanish. It's a little tricky to download, so our assistant, our executive assistant, Lisa Mendoza-Miller, has downloaded the instructions for you on how to get to it. Yay, an acronym list. Good, glad you got it there, Beatrice. So go to the NAC website, log in. If you're not already logged in, establish an account. The next one is a resource list that Lisa has put together for you with hot links. So all of these links will take you exactly to the resources that we want you to have, including the NAC governing workbook in English and Spanish. On the HRSA website, you have the summary of health center program requirements. You have samples and templates that are available in their resource center of a variety of policies and checklists that can be useful to you. You have the operational site visit guide, which is like an open book test that gives you all the questions and most of the answers before you have your operational site visit. So familiarize yourself with these tools. I want to close by reminding you of our campaign to reach 2 million agricultural workers by the year 2020. We have never arrived above 1 million. Our goal is to increase that. It is a lofty goal. We've had some setbacks this year with the new administration, but we have not given up. So if you haven't already signed up to be a part of the campaign, please do so. And I'm going to close now with my thanks to you and be open to questions that you might want to ask. So I know that's a lot of information that I've thrown at you very, very quickly, but if you don't mind taking a few minutes to put together any questions you might have, we'd be happy to try to answer them. So Sylvia, we're right around the closing time. I think what I would like to do, since I don't see any questions popping up, unless you see somebody typing, is to refer you. Go ahead.
No, I do not see anyone sending in questions.
Of all the information that I sent you, I would like to encourage you to look at the case studies. There are discussion questions that will be there, and it allows you to talk very openly among each other around risk management and corporate compliance. So I think you've been a great audience. One of the handicaps of a webinar is the fact that we can't see each other and we don't have the opportunity to interact. But I really appreciate the feedback that we are getting, and I hope that you will consider the possibility of asking for this webinar on a customized basis. If you would like to have this presented to your own board of directors, for example, if you think that this would be helpful, we'd be glad to consider doing that, and all we need is an email from you to Sylvia Gomez. Thank you, everyone.
Thank you.